I'm going to present to you the results of the clinical trial performed in our center, particularly for the RNAi. But before that, what is the progress of the development of RNAi? In fact, our heads as a first company that put this RNAi into the clinic. We know that back in 2013, they already have the data on healthy volunteer, and we start the studies, started drug on patients, and I'm going to present in much detail on the findings for this particular therapy. And Tecmira is now incorporated into our Arbutus, and we expect they will have the RNAi in the clinic very soon, and they actually have some problem early on because of the allergy problems, and they are now seems to be settling down all these particular problems. And the third company in the state is NLM, again as a company developing another RNAi, and the particular thing for this company, this drug, is that this drug can be administered through subcutaneous route. And there was a reported delay, and we don't know the reason why, but I guess probably this drug will be put in the clinic for a trial probably before 2016. They are very active in pursuing clinical trial nowadays. And we do have other companies developing the RNAi for hepatitis B, and they are at a very early stage. This slide has been already explained to you in greater detail by Dr. Given. In simple terms, the ARC-520 contains two active RNAi with a carrier molecule, and also this molecule is helping to allow these two RNAi stay in the cytoplasm of the hepatocytes. I'm not going to give another same description for this particular slides. And in clinic, we always decide what are the patients that require therapy. And broadly, we can divide our patients into two groups nowadays. Number one is whether the patient received any antiviral therapy, in particular nucleotide, nucleoside, naive or experienced patients. And we also can classify our patient into two groups. One is a E-positive group, and the other is E-negative group. So by doing this simple calculation, then we have four groups of patients: treatment naive, E-positive and E-negative, and treatment experienced, E-positive and E-negative. And I'm going to tell you the program by our heads using the R520 actually include all these four groups of patients in the clinic trial. And I will get you through one by one. And basically, for cohort 1 to 4, they are all, or 1 to 6, sorry, they are all receiving entecavir beforehand. And for cohort 1 to 4, they were all E-negative, testing with the escalating dose of R520. And for cohort 5 and 6, although it's still treatment experience, they then look at these populations is E-positive populations. So 1 to 4 is E-negative, 5 and 6 are E-positive. They're testing the dose if one dose 400 milligram or two separated dose with 2 weeks apart. The final group will be the cohort 7. This group is very special because they don't have prior entecavir treatment. So these patients, we have two subgroups, E-positive and E-negative. So these patients will receive entecavir together with the R520 at day 1. So they are treatment naive. So look at the result of the surface antigen reduction in cohort 1 to 4. I remind you that cohort 1 to 4 is a treatment experienced patient, E-negative. And you can see that unlike the profound suppression of the surface antigen in the mouse model that was already mentioned by Dr. Given, in the clinics, treatment experienced E-negative, the reduction of the surface antigen was not as much as we can expect. And only The best one we observe in this group of patients will be the 4 milligram around after one dose of 4 milligram of ARC-20, the reduction is just around 40 to 50% of the surface antigen level after one dose of infusion. So this is far from satisfactory when we look at the surface antigen response. Then we look at the cohort 5. Cohort 5 is different in the sense that although they are still treatment experienced, these patients were E positive. And you can see that the E antigen drops. This is individual patients, right? This is a plot for individual patients. They actually have a very profound drop of the E antigen just after one dose of 524 milligram per kilogram. And in fact, in this patient, you can see just after one dose, the drop of the E antigen was as high as 1.8 logs. However, when we look at the reduction of surface antigen, unlike the profound effect that we obtained in the E antigen, we are not still very satisfactory in a way that these individual patients, most of them, they have a very minimal decline or reduction of the surface antigen after one dose of ARC-20, R520, 4 milligram one dose per kilo. And there are only 2 patients with a higher reduction, around 0.5 log, or these patients around 0.7 log after one dose of the RNAi. And therefore, we are thinking why, although they have a very good drop of the E antigen, but we didn't see a very satisfactory reduction of the surface antigen for treatment experienced E positive patients. And this is the very simple cartoon which may explain why we didn't see a very dramatic drop of the surface antigen. As already mentioned by Dr. Given, the ARC-520 actually ate in this particular site. So it actually quite depends on the presence of the region that contain the DR region. So if the patients have a very high populated hepatocyte with integrated DNA, the potential target sites for the ARC-520 is actually gone. And therefore, with this transcript, the ARC-520 cannot act on the surface and the mRNA synthesized by the integrated genome. And this is actually very compatible with what they observed in the chimpanzee experiment. And in fact, in the chimpanzee experiment, they have the insight of the distribution or the contribution of the surface antigen from these 2 groups of patients, E negative patients and E positive patients. This is an individual chimpanzee, and the first 3 were E negative, and the last 5 were E positive. You can see that the transcript that they obtain for the E negative chimpanzees, they do not have much transcript containing the targeting region at the DR region. However, with the E positive chimpanzee, they still have many transcripts that contain the DR region. So in the E positive chimps, the relative balance of transcription of the surface antigen and other CcDNA transcript were detected. And for E negative chimps, the surface antigen transcript make up a high proportion of the HBV transcript. And the frequency of the surface gene transcript which is reduced in the region upstream of the DR1 site. So if the ARC-520 is acting predominantly in this sites, then there will be no adding region or site for this drug to add in E negative patients, where the surface antigen are mainly produced by the integrated DNA. So these results are indicative of surface antigen expression from the integrated DNA. And in fact, we have some circumstantial evidence, not only from this TRIM experiment. When we look at our patients with a very long-term treatment of lupus, at baseline, 1 year, and more than 5 years of therapy. We measure all the parameters, so serum DNA, intrahepatic HBeDNA, the CcDNA, and the surface antigen. What we can see is after at least 5 years, long therapy of nucleotide analog, the DNA drop in the serum dropped very well. The intrahepatic DNA dropped very well. The CcDNA also dropped because of lateral cell death. However, we didn't see a significant drop of the surface antigen, even though the CcDNA content has been diminished. And this indirectly suggests that these patients with a very prolonged nucleoside therapy, the fact that they do not have a significant drop of surface antigen is maybe referring to the synthesis of the surface antigen from the integrated DNA. Therefore, it pushed Arrowhead to study the last group of patients, which may have less integrated DNA. And these are the patients who are treatment naive, E positive, or E negative. That means it is the cohort 7 that I was referring to you earlier on. So this is a detail of the cohort 7 patients. And you can see that for E negative group, the reduction of the surface antigen is actually not very obvious. And the response actually was quite delayed, not until day 30. And this is only plot for the single patients. These patients have E positive at the beginning, and during the study, these patients have a E antigen zero conversion. So the drop of the surface antigen is better than the E negative group. However, when we look at the E positive treatment naive group, then you can see that the surface antigen actually dropped quite a lot. The median was 1.4 logs after just one dose of the ARC-520. And this is the detail of every single patient in this cohort in terms of the reduction of surface antigen. You can see that of the 5 out of the 6 E-positive patients, we have patients with a maximum surface antigen reduction of 1.8 log. The mean surface antigen reduction was 1.5. And in fact, the surface antigen level was still reduced 85 days just after one dose of the ARC-520. And this is only one patient with transitional stage. That means the patient with E positive will start, and then with a zero conversion or E negative at the day between the day 3 to day 45. For E negative group, 5 of 6 patients had undetectable or very low surface antigen, and we only have one patient who have a very moderate drop of the surface antigen of 0.5 log. We also have a chance to look at a more novel marker, the core-related antigen that was measured in our laboratory with a collaboration between the company between us and the company in Japan. And you can see that for E-positive patients, the maximum reduction of core-related antigen was actually very similar to the surface antigen, as 1.8 logs with a mean of reduction of 1.4. And most of E-negative patients, they have a lower level of core-related antigen below the limit of detection. There's only one patient in the E-negative group have the detectable core-related antigen, and these patients have 0.5 log reduction. How about the DNA? Again, of the 5 out of 6 E-positive patients above with a detectable HBeDNA, the reduction was actually very obvious. 5.5 log with the mean reduction of 4.7 log. And all the E-negative and the one with transitional states achieved the HBeDNA below the detection limit. And you can see that this is a very nice drop of surface antigen of E-positive patients. How about the E antigen? Again, very similar plot when we compare this with the core-related antigen. 5 out of 6 E-positive patients have the detectable or measurable E antigen, and then the maximum reduction of E antigen was 2 log, and the mean reduction was around 1.6 log. So this is a summary, very busy slide, but this is a summary of the reduction of all the viral proteins, surface antigen, core-related antigen, and E antigen. I just want to draw your attention by comparing two groups. In cohort 5, E-positive patients, treatment experience, this is the reduction of surface antigen, okay? Maximum 0.7 for surface antigen, 1.1 for core-related antigen, 1.7 for E antigen. When you compare this with at the same group of E-positive patients but treatment naive, then you can see the reduction of the maximum reduction of surface antigen is 1.8 compared to 0.7. For core-related antigen, 1.8 compared to 1.1, and for E antigen, 2.0 compared to 1.7. So it seems that the best group of patients with the best benefit or best reduction of the R520 is the patients who are E-positive, who are not having a prior nucleoside analog therapy. So finally, these are the AE, adverse event of the studies. And this is coming from the very early studies involving the healthy volunteers. You can see that compare placebo with patients with receiving active medications, there were no significant difference in terms of the possible AE. And when we look at the clinic, clinic patients, we didn't see a dose proportional increase in the AE across the different dose of patients. And in fact, they somehow with a lower group, lower dose group, the side effects actually clustering within this particular group. But even with increasing dose of 4 milligram kilogram, we didn't see any significant major AE occurred so far in a clinical trial. So, ladies and gentlemen, I would like to conclude by saying that R520 were very well tolerated, and this medication or this study drug plus entecavir produce a very rapid DNA suppression consistent with their synergistic activity shown in preclinical studies. R520 effectively inhibit the CcDNA-derived mRNA with viral protein reduction of up to 2 logs in the best group of patients. In E-positive patients, treatment naive, all the viral antigens were effectively suppressed, while in the E-negative patients, we see a less reduction in surface antigen. And these findings are consistent with the more CcDNA driven and antigen production in naive E-positive patients, and a higher fraction of the surface antigen production from the integrated DNA in the E-negative patients. And these variations in viral protein knockdown are consistent with data from the chimp, showing a high fractions of the integrated DNA-derived mRNA in E-negative animals. Integration of the HBDNA results in deletions near the DR sites, and the viral mRNA expressed from the integrated DNA can lose the potential target for R520. And finally, the chronic R520 are now ongoing, and we really aim to produce a real figure on the surface antigen zero clearance. And finally, these are the collaborators who involved in all these studies. Thank you very much.